Hello, my name is Alon Avidan. I'm a professor of neurology and vice chair of clinical and educational affairs in the Department of Neurology at UCLA. I'm going to give you a presentation on sleep disorders and share with you some of my knowledge of sleep medicine and discuss some of the most common and prevalent sleep disorders that we usually see in our sleep disorders clinic. I want to make this presentation both relevant and also useful, so you will gain from it some of my knowledge of how to at least think of some of the sleep disorders in your own mind and conceptualize a framework for appreciating some of the pathophysiology and how we as sleep physicians assess for the sleep disorders and manage and evaluate them. So the title of the presentation is trying to explore sleep disorders, and with that we'd like to make a recommendation for anyone who has any questions to go ahead and tweet them using Twitter, using the hashtag UCLAMDChat, or comment using Facebook. The first question that I usually get from most patients is, why do we sleep? What's the function of sleep? Well, there are at least a dozen of theories of the function of sleep, and the latest and probably the most elegant theory of why we sleep is that during sleep we have a system in our brain called the glymphatic system. The glymphatic system, in a way, is the brain's own lymphatic system that essentially cleans the brain tissue out of all kinds of toxins and byproducts. And the glymphatic system is exclusively effective and active during the night. It doesn't function during the daytime. So in this cartoon, you can see the brain's glymphatic system being active during the nighttime, and essentially the cleaning mechanism is primarily effective during the night, and this is where you see neuronal and tissue repair and the glymphatic system. As you can see, all the toxins and the cellular metabolites are getting cleaned during the night, and what ends up happening is if you don't get sufficient amount of sleep, it's been shown in laboratory animals that those proteins tend to accumulate, and particularly in rats, it's been shown that there is a potential accumulation of beta amyloid. And beta amyloid, for those of you who may remember, beta amyloid is the building block of what we find in Alzheimer's dementia. So at least in mice and rats, we know that beta amyloid is potentially building up in rats that are not getting sufficient amount of sleep. That has not really been replicated yet in humans, but it's very intriguing and quite fascinating. So the glymphatic system, the cleaning out of the brain, out of its toxins during the night, is one intriguing theory that is explaining potentially part of the reason why we sleep, in that it's a potential time of cellular repair and cleaning out process that is really conducive for our ability to clean out and undergo tissue repair during the night. A second theory is for memory consolidation. What ends up happening is during the day we accumulate a lot of information, and this information has to be consolidated. And the only time and the only effective way to do it is during the night, when all this information gets consolidated. And think of it as a disk defragmentation program that takes information that is not needed and essentially tends to consolidate it, making more room for information that we do need to store for survival. So memory consolidation is another useful and potentially helpful mechanism that helps explain the process of and the need for sleep. Okay. Another very important concept that patients often ask me is, how does sleep change during the 24-hour cycle? How does it fluctuate? And I'd like to show you a diagram. This is what happens to wake propensity during the 24-hour cycle. And wake propensity simply explains how relative sleep or wake you are during the day and during the night. And it helps explain a lot of things. For example, it may help explain why most people are feeling a little bit sleepy around 3 p.m., just around this time period. And I've attached a cartoon of a battery, relative percentage of a battery charge during the wake and sleep time. So you can see on the x-axis the time during the day, starting at 9 a.m., going to 3 p.m., 9 p.m., 3 a.m., and back to 9 a.m. On the y-axis, you can see the interaction of the sleep load and the internal circadian mechanism. And that interaction produces the wake propensity curve. And what you can see is that when we wake up at 9 a.m., most of us are very energetic and we're all very, very alert. And then around 9 p.m., we kind of feel a little bit sleepy. That's when we usually need to take a siesta or a cup of coffee. And then we usually get more energized and back to our second wind around 8 to 9 p.m. And just around 9 p.m., right after 9 p.m., that's when melatonin is getting secreted. And that's when we feel a little bit sleepy, thanks to melatonin. And that's when we find that we feel sleepy. And that's when we go to bed. And that's useful physiologically. And our wake propensity is really minimum, just around bedtime. And then we wake up again around 9 a.m., thanks to another neurotransmitter called histamine. And that's when melatonin levels begin to drop, preparing us to start the wake period just around the morning time. And this is helpful because it helps you appreciate what is the anticipated level of sleepiness and wakefulness during the 24-hour period as you try to know what is really normal baseline as opposed to what's pathologic. What you can appreciate is that certain periods of the 24-hour cycle are likely to put people at risk for sleep-related accidents. Remember this time period? This is a time period just around 3 to 4 a.m. that our wake propensity is at its lowest. When we ask people to be alert here, for example, shift workers or people who are operating heavy machinery or have to be alert when their circadian clock is telling them to be asleep, that's when they run into problems. So if you look at historical issues with occupational accidents like Chernobyl, Exxon Valdez, single vehicle accidents, they all occur between 3 to 4 a.m. And it's very interesting because this is when our circadian clock is at its lowest alertness signaling, which means that this is important for everyone to consider. If they're shift workers, that's when they're more likely to be sleepy. Let's talk a little bit about sleep physiology. And it's important because when we conduct sleep studies, people ask us, well, what is a normal sleep architecture or sleep staging? Sleep staging is essentially a marker of what is the brain signaling, the EEG signal, the brainwave signal, as it demarcates the brain wave frequency as we go through sleep and wakefulness. Sleep is divided into rapid eye movement sleep and non-rapid eye movement sleep. Rapid eye movement sleep makes about 25% of total sleep time. The rest, about 75%, is non-rapid eye movement sleep. And why is that important? Well, it's important because people who do not have enough REM sleep are more likely to be on medications such as antidepressants that potentially reduce the percentage of REM sleep. So clinically, it may have some importance, but it's important to also remember that this percentage may vary by age. For example, older adults may have less REM sleep. Older adults may have also less deep sleep, and that's important because it essentially varies as we grow older, and younger people, of course, will have more slow wave sleep. So it's important to just remind people that their sleep architecture may vary across the life cycle. How much sleep do we need? That's another question that people ask me, and the answer is that it changes from decade to decade. But by and large, for individuals between over 18 years of age, 7 to 9 hours of sleep is usually recommended. Anyone who sleeps less than 7 hours is probably at risk of sleep deprivation. 12 to 18-year-olds should probably get about 8.5 to 9 hours. Babies and newborns probably sleep about more than 2/3 of their 24-hour period. Older adults need as much sleep as younger adults. The problem is that their ability to sleep is disrupted. It's not that they need less sleep, and that's an important issue to remember. But just as a rule of thumb, 7 to 8 hours of sleep. If you're getting less than 7 hours, you're probably setting yourself up for sleep deprivation, so remember that. Let's talk about what is the difference between insomnia and sleep deprivation. A lot of people come to see me and they complain that they're very sleepy. And when we look at their sleep log or sleep diary, meaning how much sleep are they getting every single day for 1 or 2 weeks, we find that they're actually not sleeping enough. So that sleep deprivation is actually the number one reason why people are too sleepy. So just to remind everyone, insomnia is defined by the fact that people have enough sleep opportunity, but they have a reduced sleep ability. They just cannot fall asleep and they cannot maintain sleep. Sleep loss or sleep deprivation is defined by reduced sleep opportunity, okay? And they have enough adequacy, good adequacy of sleep ability. So that's really important to remember as we define sleep deprivation or insomnia. So what are the most common causes of sleepiness in the United States? And the number one cause of sleepiness is probably insufficient sleep, not setting yourself for enough opportunity for sleep. Medications such as antidepressants are also very common causes. Fragmented sleep, like residents on call getting pagers. Primary sleep disorders like obstructive sleep apnea, periodic leg movements. Mood disorders like depression. Circadian rhythm disorders are usually defined by a mismatch between the circadian clock cycle and what the patient's cycle demonstrates. So for example, if a teenager goes to bed at 2 or 3 in the morning and can get up until 10 or 11 a.m. the next day, that's a delayed sleep phase syndrome, and that's a disorder that often manifests with daytime sleepiness and also with insomnia. Also, we know that new parents also forgo about 6 months total of sleep deprivation in the first 2 years after the baby is born. A good reason to be sleep deprived, but yet very important to remember that social factors are also playing a role a major role in sleep deprivation. Insomnia is probably one of the most prevalent sleep disorders. About 10% of Americans have chronic insomnia, insomnia defined for more than 3 months. Very interestingly, many patients use over-the-counter medications like Benadryl, Tylenol PM, diphenylhydramine, with little evidence that these medications are safe or effective. Melatonin is being used, and we don't really have good data that melatonin is effective or safe. Alcohol is used as many as 2/3 of patients, again with very little evidence about safety, efficacy, and we have many concerns about the problem with melatonin, with alcohol, in that it can lead to dependence and it can actually worsen and exacerbate patients who may have sleep apnea. Obstructive sleep apnea syndrome, this is probably the most dangerous sleep disorder. And the reason why is when you're not breathing at night, your blood pressure goes up. You may be setting yourself up for heart attacks, early death from arrhythmias, stroke, diabetes because you're not sleeping sufficiently and your sleep is disrupted. Just to think anatomically of what causes sleep apnea, we know that patients who have obstructive sleep apnea have an obstruction right at the level of the region in the upper airways where the tongue and the soft palate come into contact, right around here. This is called the hypopharyngeal airway. And this point of contact is affected by gravity, it's affected by weight, it's affected by alcohol, it's also affected by changes in the tissue by aging. So all factors including advanced age, obesity, gravity, meaning sleeping on your back, and factors such as increased size of the tongue put patients at risk for obstructive sleep apnea syndrome. In children, the number one cause of obstructive sleep apnea is the presence of increased size of the tonsils and the adenoids. And removing the tonsils and adenoids usually cures obstructive sleep apnea. In adults, this is a little bit more complicated. You really need to think of sleep apnea as affecting the entire soft tissue size, and it's a little bit more complicated to treat. This is what sleep apnea looks like on a sleep study. On a sleep study, we monitor the brain waves, the EKG, as you can see here, airflow and effort. And it just shows you that a patient with obstructive sleep apnea doesn't have the airflow, they have an obstruction, and they're still trying to breathe. They still are trying to generate an airflow. And this is called obstructive sleep apnea, which is very different than central sleep apnea, where they don't have an airflow and they don't have effort, which is very different than obstructive sleep apnea. Really, the best treatment and the most effective way to treat sleep apnea is using what's called CPAP. CPAP stands for continuous positive airway pressure. This is the gold standard treatment for obstructive sleep apnea. I want to show you on this cartoon what it looks like. The patient wears a mask that's connected to a pressure generator. The pressure generator essentially pushes air into the patient's airways and keeps it open. And you can see what happens. This is a cross-section through the patient's airways, and you can see what happens when we don't use CPAP and what happens when we start putting the patient on CPAP at the level of 5, 10, and 15. And you can see a very nice expansion of the upper airways. So this is really beautifully demonstrated in this cartoon. And this is what it looks like. The CPAP has a mask that fits over the patient's nose and mouth, a tube that's connected to a pressure generator that essentially pushes the air to split the airways open. Just to show you what happens on a sleep study before we apply CPAP and with the application of CPAP, you can see a very nice improvement of the level of the oxygen saturation. Here without CPAP, the patient has really bad oxygen level dropping to a very dangerous level. And with the application of CPAP, you improve the oxygen level and you also improve the patient's sleep quality. They're actually able to dream again. They're going to have more consolidated sleep and less fragmentation, and hence better sleep quality. There are now also dental devices that allow the patient to wear a dental appliance, and it helps people with milder degrees of sleep apnea who do not want to carry the CPAP when they travel. Granted, these are only effective if the patient has a milder form of sleep apnea. Restless leg syndrome is another sleep disorder where the patient has an urge to move the legs. The urge to move the legs is usually worse when they're at rest. Getting up and moving usually gets rid of it, and the patient usually experiences the symptoms during the evening time. And this is a very fascinating condition because patients often don't recognize that they have this condition, and it's usually very effectively treated with a class of medications called dopamine agonists. Narcolepsy. Narcolepsy is a fascinating condition. It's usually characterized by severe daytime sleepiness and also very peculiar phenomenon of what we call rapid eye movement sleep, intrusion phenomenon like cataplexy. Cataplexy occurs when people lose their muscle tone when they hear a funny joke. And this is actually very, very disruptive because a patient may be playing football or soccer and they get really excited when they hit a ball and they fall to the ground. They essentially lose their muscle tone. So that's cataplexy. Cataplexy with daytime sleepiness is almost unequivocally narcolepsy. All right, I'm going to conclude with parasomnias. I'm a neurologist, so I really am fascinated by all kinds of unusual movements and behaviors that occur at night. One of the most fascinating parasomnias in my mind is a parasomnia called rapid eye movement sleep behavior disorder, which occurs when people act out their dreams. They actually punch, kick, scream, yell, and when an older adult does this, and they're yelling, screaming, fighting, punching, it is usually predictive and actually means that the patient could go on to develop a neurodegenerative disease. And I think that's a really important condition never to overlook because it predicts that a patient with this parasomnia may go on to develop a neurodegenerative disease. So if you know of anyone or if you have heard of anyone who is fighting or acting out their dreams, they should really go and see their primary physician because it could mean that they could develop a neurologic condition later in life. So with that, I'm going to end the formal presentation, and I think we have a few questions to go through that have come in during the presentation. Now let's take a look through some of this. The first question is, Doctor, how much sleep should I be getting? And I think we went through this question already. It depends on the age of the patient, but by and large, for anyone over age 18, the minimum number of hours required is 7 and above. The average is about between 7 to 8. If you're getting 7 to 8 hours of sleep, I think you're doing fine. I have some patients who are telling me, you know, doctor, I'm sleeping about 5 hours, but then I'm sleeping 2 hours between 1 to 3 p.m. So 2 plus 5 equals 7. So I'm sleeping enough. You know, I just want to mention sleep is not a bank account. You can't add 2 and 5 and say you're sleeping 7. It's ideally best to be taken during the night. And by the way, if your nap is longer than 15 or 20 minutes, it's not a good idea. The power nap is ideally between 15 and 20 minutes between 1 to 3 p.m. If the nap is longer than 30 minutes, you're more likely to wake up groggy from it. A power nap is 15 to 20 minutes between 1 to 3 p.m. If it's longer than, if you're taking it too late, you're going to have problems with insomnia. And if it's longer than 30 minutes, you're going to be more groggy when you wake up because you're more likely to go into slow wave sleep if you wake up from a power nap that is an hour long, for example. Okay, here is another question. If I cannot fall asleep, can I have a shot of whiskey before bedtime? Now, that's a question I get from patients who have insomnia. They always want to see if alcohol can help them fall asleep. And alcohol is very enticing, right? It makes you very sleepy. But there is a problem. What happens when you fall asleep? You stop drinking. And then you wake up and you can fall asleep. The problem with alcohol is that it has a short half-life, meaning that it puts you to sleep, but then you wake up, and you wake up frequently. There is an issue of dependence, meaning that once you start it, it's hard to come off of it. And there is an issue of tolerance, whereas one night you can do well with 1 shot of whiskey, the next night you need 2, and then you need more and more to have the same effect. And we know that alcohol is not a good drug for insomnia because it destroys your sleep architecture. It essentially disrupts the normal architecture of sleep physiology. So never a good idea for insomnia. Let's do maybe 1 or 2 more. Here's another question. My doctor gave me a sleep aid, and I found out that I may have eaten in the middle of the night ever since. Should I be worried? So this is a phenomenon named as sleep-related eating or sleep nocturnal eating disorder, which is a parasomnia, much like I've mentioned earlier, where people have movements or behaviors during the night for which they have no recollection. And this particular parasomnia, which is probably related to a hypnotic, nocturnal eating or amnestic sleep-related eating is the most common parasomnia related to a hypnotic, most likely zolpidem or Ambien. And what ends up happening is people may have amnestic eating. They may eat things and have no recollection. I've had patients who may have eaten from a jar of mayonnaise and had no recollection. I had one patient who prepared a raspberry and cat food sandwich and had no recollection, only to find out the remnants the next day. And it's fascinating. The problem with this parasomnias is the safety of preparing food and maybe cutting yourself as you're making the sandwiches, turning on the stove and engaging in the food preparation, and also weight gain, because a lot of the food items are particularly high calories. So that's another issue. And many of these amnestic behaviors can also involve sleep driving. I've had a patient who, after being placed on a hypnotic, began to drive and had no recollection the next day. So, and it's an important issue, and we as physicians, the moment we hear about this, I think it should be a red flag to discontinue the medication immediately. Okay, last question. I get this terrible urge to move the legs in the evening time. What is this called, and is there a cure? Well, we went over this condition. This is called restless leg syndrome. Restless leg syndrome is described as an urge to move the legs, worse in the evening time. It gets better when the patient moves, and it gets worse during inactivity. And there is treatment. There is no cure yet. There is treatment using a class of medications called dopamine agonists and another class of medication called alpha-2 delta ligands. The medication are quite effective, and if you have these conditions, certainly I think it's important for you to see your primary care physician because the treatments are quite effective. So I think our time is up, and I really enjoyed being able to participate in this webinar. Thank you very much. If you have more questions, please go ahead and ask them using the Twitter account, #UCLAMDChat, or comment on Facebook. Thank you very much.